Hey, welcome back to Practitioner Tuesday Training, where practitioners meet every week to talk all things client work for the clients and patients that they serve to get them out of pain. I am your host, Gina Schatz, and I am with you for the next hour to talk shop. Today, we're going to talk about trigger points. Actually, what we're going to talk about is why I no longer treat trigger points, and there's a reason for that. Hey, Michelle in the club seats. Nice to see you. Hello, hello. I'm glad that you're here. We are going to explore trigger points through the lens of how I used to use them and why I no longer use them and how come. And yeah, Michelle's like, yes, okay, good. So I hope that you guys that are watching here on YouTube are also accessing the chat section, the comment section. Hi, everybody. I can see you guys now. It was super easy to log in today. I do want us to talk about this because the whole point of our June focus is on master practitioner practices so that we can get on to doing big things and have it be simple. So I don't think doing high level clinical work is easy. I do believe that there's a learning curve and that we get to dive in and we get to have really strong strategic thinking that allows us to sort through a huge file box of anatomical information. All of that, yes. And once we have all of that, then it can be a simpler approach to resolving complex issues. So if you guys are on board for that, then this is the month for you, because that's what we're focused on in June, and specifically today on the trigger point part of it. Last week we talked fascia, and interestingly enough, there is a crossover between fascia and trigger points. And I was reminded of that just recently as I was putting our content together for the month that the first place I went to was trigger points. Then I went to fascia because they were connected. And I, like some of you might be doing this, I kept looking for the next thing, the next thing, the next thing. And you guys have heard me say this before that there isn't really one technique that is the magic bullet. I wish there was. Like, I wish that was how it could be simple and easy for us. But if there was one technique that was the magic bullet, we would all be using it. So there isn't one. And that doesn't mean that you shouldn't train in other techniques. That's also not what I mean. But in order for the technique to have value for you, what I want for the technique trainings to offer is the anatomy behind the technique, how the technique got to be needed, and what else could also be needed. Because a technique is just not a magic bullet. Even it's not the only thing, like there isn't one technique that is a magic bullet, and a technique in a treatment plan is not going to solve the whole bundle. It just isn't. And I say that from decades of clinical experience. Believe me, if there was, I am the most efficient person that I know when it comes to bodywork and solving pain. I want it done fast. If there was a way to do that, I would have adopted that already. So there is value in learning techniques for sure, but I want us to get our minds right about that and use the training around the technique in a way that can serve us in a whole perspective, not in a blinders on, let me just make this easy and not look at all the rest kind of way. And if we can get our minds in that space, then we'll actually derive a lot more value from the training around techniques. Hey, Gary in the club seats, nice to see you. I'm glad that you're here too. Hello, hello. So yesterday for those of you who joined me for the Way of the Master Practitioner training, which was awesome sauce, by the way. I'm so glad you guys were there. Thanks, Gary. I'm glad you were there. You loved it. Perfect. Amazing. We talked about, in that training, we talked about what does it really require that I have come to know after, again, several decades at this full-time practice. What does it really take to be a master at the craft of bodywork? And when I say a master, I mean specifically a master at eradicating pain, not just soothing it for a while or helping it quell for a bit or wanting it enough. But I mean, like, I actually know what caused it. I know how to get to the genesis and I know what to do about that to then eradicate it so it doesn't return. And the reason that I know that that's possible, and I believe wholeheartedly that that's possible, is because the anatomy tells us that. When we are aligned the way our body is designed, and when we are functioning the way our body is designed to function, there is no pain. That's the point, because we didn't come with any pain. We developed to also not have pain. So something about the pain idea, and I have no hesitation or squeamishness around four-letter words, but this one four-letter word gives me pause because the word pain means something in the design and or the function is not being respected and utilized the way it was designed and the way it was designed to function. That's what leads us to pain. So I'm not upset about the word pain, but I'm not panicked about the word pain. And most of the pain that we experience is symptomatic of something that caused it. And this matters as we start talking about trigger points today. So if something caused that pain and the pain itself is just a message, and we use more anatomy that tells us that 80 to 90% of said pain is referred, then we're really not going to do well by focus on the pain point. We're not going to create that full solution to eradicating the pain and restoring our body back to its design and restoring it back to functioning in that design. We're not going to do that by just pointing at the pain spot, the symptom that was a generation of accumulated effect that then landed in this one spot, and the body finally said, okay, I need a little help here. The other thing about pain and the nature of it is that it doesn't typically show up in an instant. There's a graduation that's like, okay, well, I didn't really like, okay, well, let me try again. Well, okay, well, and that's because of our design. We're designed with reciprocal inhibition, where there's a whole gaggle of synergists, and anybody can jump in and do a little bit more or a little bit less to get the job done. We're built with a nervous system that allows us to do crazy ass things. Like right now, why am I sitting on one foot? Why? Why do I have my pelvis cocked like that? I know better. But if, yeah, you too, Michelle. Okay, like, right, yeah, exactly. And I sat on my bum all day yesterday training, and I was like, I need a standing desk. But still, it's the way we sit and the way we stand. It's not the desk, it's not the chair, it's not the car seat, it's not the computer, it's not all that. Like, are we using our body the way it was designed? And by using, I mean functioning the way we're designed. If the answer is yes, there's no pain. If the answer is no, the body's going to try to make concessions for that. Because if we had a pain message every time we tinkered with the design and the function, we would all be in excruciating pain for like the entirety of our existence as humans. And that's just not how we're wired. We're actually wired with a lot of benefit of the doubt, right? Like a lot of support in this beautiful design. So as master practitioners, we get to know that. Like know it without being distracted by anything else is possible. I know that the client that comes has pain from a body that tried already, heaven knows how many times before the pain manifested and wouldn't go away, and then they came to see me. I get to know that going in. If you know that going in, you won't just go to the symptom and start what I'm now calling smack the symptom. You need to not be there. You need to not be there. The symptom is actually telling us a story that happened, an experience that the body is trying to make sense of on its own, that probably did make sense of it for a minute, for a blip in time. And if we also use our anatomical math, victim cries, perpetrator doesn't. That's cute. I mean, kind of eerily cute, but yes, that's a good one, Michelle. I like that. So if we recognize that and we also remember that 80 to 90% of the pain in the body is referred, then that helps us recognize what the body attempted to do on its own and what the story in that attempt might have been before it raised its hand, which is just where the symptom is. Okay. And then we're not going to treat the raised hand. We're going to treat what caused it to raise its hand. Okay. We all know this. We're nodding. Amazing. That knowing doesn't take very long. Like one or two times you hear it and you're like, okay, it makes total sense. Because the truth always makes sense, by the way, even if you've never heard it before, there's something in you that's like a yes to the truth, always, your truth. And when it comes to the body, I believe there's universal truth. So we all kind of get it. We're like, yes, of course. How to find the genesis and interpret what the body went through before it raised its hand is the skill of a master practitioner. That doesn't come in an instant. That comes with a lot of anatomy and understanding the nature of the injury and how things compensate and recruit, and then how it could show up and then still function and then raise its hand because it's done with that without pain. That's all the strategic thinking that requires training. And once you get that, it makes it super simple. But it's not easy to learn how to do that. You gotta know a lot and not know a lot and know a lot again and keep synthesizing that. And that's what we train for. Today, though, we're going to talk about trigger points. And I wanted to give you that backdrop because the trigger points are the raised hand. Hello, I have a trigger point here. I have done this thing in this muscle to tell you that I tried and now I can't try. I am out of tries. I'm out of tries. Okay. I'm almost hesitant to bring up this conversation, which clearly I'm not. I'm live here on the freaking internet, but I'm going to bring it up. But I thought about it. Like, do I? Do I not? Do I? Do I not? Because I have to tell you guys, this was a turning point for me, a huge turning point for me in my ability to eradicate pain, not just treat it, but eradicate it. And there's a difference. Treating pain means I have pain. I'm going to make you feel better until you don't. I have pain. I'm going to make you feel better until you don't. I have pain. I'm going to make you. That's treating it. Eradicating it is I have pain. Oh, tell me all the things that you went through so that I could follow the line and clear that road so that you don't have to raise your hand anymore. It's not the same type of approach. Totally different. Okay, I'm glad you're nodding, Michelle. This is great. So when I first learned about trigger points, and I have the hundred and some dollar textbook to prove that I was committed. I even have my name stickered on the inside. I mean, I was in. I was like, oh, volume one. Will I ever be able to afford volume two? Oh, I love this book. And I would open up the book and I would read it for like entertainment. And I would look at the tracings of all of the trigger point patterns that were drawn and where they all lived. And I would remember, oh, yeah, that's what that muscle does. And this is where it innervates. Oh, and this is where the referral pattern goes. That must be what they mean when they say pain is referred. Because here's the source and it refers to there. That's what I think this means. Okay, I'm on it. Yes. Baby, teach me, be the doctor. And I love Janet Travell. I love this book. Look at how clean these edges are, you guys. And if I told you how old this book is probably older than some of you. I'm not even kidding you. This is like, well, it says 3/13/90 something, and then the dates. You have volume three now. I wonder what volume this is. Volume one. Okay, so this is volume, this is like the OG. Okay. So I was in it, and I want to share that with you so that you know I'm not just here to sensationalize anything. I'm not here to throw anybody else under the bus. Like I'm not here to do that. I'm supporting you in knowing how I work to make it quicker. When I got into this trigger point business, we were also at that time using fluoromethane. Did you use fluoromethane, Michelle? Did you ever use that, the spray? Gary, ever heard of it? Yeah, we'd have to shake the bottle and hold it upside down, and you had to spray it in the striations of the muscle that had the trigger point in it. You had to get a prescription for it. You couldn't just go and buy it off the shelf. It was like a big deal. And it was working because I would study these muscles and these patterns, and I would do exactly on the striations and exactly the right stream of my fluoromethane. And people were like, oh, the muscle's back. And I don't have any pain when I do the thing anymore. This is it. And I was like, I'm done. This is just sign, seal, and deliver me, baby. You lick the sticker on the envelope and mail me because I've arrived. Like this is it. This is amazing. And then, just like you guys, the clients would come back. I need that spray again on that trigger point. I could tell it was the trigger point. It was exactly where you pointed before, Gina, and it referred down just like you said it would. And I recognize it now. So I need more trigger point work. Okay, well then let's do it again. And I'll be honest with you, the second time it happened, I was like, where in this book does it say that it will come back? What? the hell? I sprayed that puppy. Why did it, why are we doing this again? This is boring to me. To repeat, this is boring. I don't understand. And I thought, well, Gina, it's a big book. Like you got to read more. Agonist, antagonist, Michelle. Cool. Love this. Absolutely. You got to read more, I thought. I'm just gonna have to, I got to figure out more. There must be more that I missed. There must be more trigger points, more muscles, agonist and antagonist. Sure. Synergists even. Okay, now I gotta know agonists and antagonists and synergists of reciprocal inhibition. And I didn't learn that because I was a body worker and they don't teach movement in body work. Okay, so let me learn that. Then I'll learn more muscles and then I'll go right back to trigger point work. That'll be it. Except all I was doing was running out of fluoromethane spray because now every freaking muscle got sprayed. And then I remember when they eliminated our ability to have access to fluoromethane, and I was like, I'm not an addict of any type except for maybe sugar, but no street drugs, and I was like a crack addict. I was like, someone's got to get me this fluoromethane spray. Like I'm going down without this spray. Like I don't care if it's on the black market. Like I got to get some fluoromethane spray. And I remember, sir, this was in the 90s, Gary. I'm dating myself, but I've been at this a long time. That's my point. Like I know a thing or two. I took the long road and now I got to on the short bus and now I'm on the long bus going faster. Like we can get there further faster. And this is how. So I was tracing down this fluoromethane spray and I was finally I was friends with the president of my massage therapy school. This is long after I graduated, obviously. And I went back and I was like, where do you get it? Because I know that you know how to get it. And he was like, why do you need it? I was like, hello, have you not read the Bible? Like, why, why did I pay you all that money to go to school if you're not even on board? And he was like, yeah, but why do you need it? Why do you need that much? And I was like, because I'm treating trigger points successfully and it's getting my clients out of pain. So now they know that that's what they need. So I'm continuing to treat trigger points. And I could hear the Groundhog Day in that, but it didn't land because I was still like hungry like an addict. And he said, well, why don't you just use ice then? I was like, oh, will that do the same thing? He's like, it's basically like a deep freeze for the muscles. This fluoromethane spray is like a deep freeze for the muscle spindles so that you can deactivate the trigger point, go in and manually remove it, supposedly. But I do have talented fingers, so I did believe that's what was happening. And you could just deactivate the active trigger point by icing it, although it would take longer and it's a little bit messier. And it was. I was melting ice cubes down people's deltoids right onto my treatment table, and it was hecka messy. And it didn't quite do the same thing as the fluoromethane spray, but if I'm honest, because of my need for speed, I probably didn't do it long enough. Fluoromethane spray probably worked faster than what I was willing to spend on ice, which is probably why they made the spray in the first place, blah, blah, blah. So as I was waiting for probably the 18th ice cube to melt down my client's deltoid, I'm using that as an example, it kind of clicked that I was in Groundhog's Day and insisting on that. And then I was like, yeah, I'm onto something here. This isn't working. Even if I did the agonist and the antagonist, why do I need to do that? Why did those two muscles start showing up that way? How did they cause the trigger point in the first place? Because we didn't come with them, we made them. In our design, with our alignment and our function and our form, there's no pain. There's no adhesions, there's no trigger points, there's no tightness, there's none of the symptoms that we find over here in the original design format. There aren't any. So how did they get there? And then that's when the floodgates opened and I realized I'm treating the wrong thing. I'm doing really excellent alleviating of said trigger points, even without the fluoromethane spray, although I did better with the spray because it was quicker. But if I keep treating trigger points and I'm not addressing how they formed in the first place, I haven't solved the problem. And that is where we get to really do masterful work. What caused the agonist or the antagonist or a synergist or multiple synergists or the stabilizer to have a trigger point in it in the first place? It's just like what we said last week. What caused all this fascia to bind that we're so happy fascia workers about? And as I mentioned, I went from trigger point myotherapy and notice what it says, myofascial pain. And so I thought, okay, maybe it's the fascia. Maybe it's not the trigger point. Maybe it's the fascia around the muscle that caused the muscle to cause the trigger point. All right, now I'm going to study fascia. And I did for a long time. And I shared that with you guys last week until I had the same epiphany. How did the fascia bind? There's no binding of fascia over here. There's no binding of fascia. There's no adhesions. There's no trigger points. There's no tight muscles. How did that happen? Oh, because the agonist and the antagonist weren't working. That caused the fascia to bind. But why weren't the agonist and antagonists working? What caused that? Because over here, all the muscles work in reciprocal inhibition. But now I'm over here and they're not working and having satellite issues like bound fascia and trigger points and active trigger points and latent trigger points and satellite trigger points and all kinds of fancy trigger points. But how did that happen? And how do I get them back over here? Central nervous system. Maybe. Why did the central nervous system send that message? Because the central nervous system is wired to hold all of this. So metabolic. So here's where I landed with that. We get to keep finding the genesis and we get to be super clear on what is a symptom. Because if we're still treating symptoms and we're blaming a symptom or assigning a symptom with another symptom's calling, then we're still just symptom stacking and trying to smack them all back down. And that's what techniques are for. That's what techniques are for. There's a bound amount of fascia. We need to unbind the fascia. Yes, we do. That's a symptom, and that's a technique to unbind that. Nothing wrong with that technique. Nothing wrong with that piece of anatomy. It showed up in our design. There's nothing in our design that's superfluous. Fascia is just as important as muscles, just as important as bones, just as important as the nervous system. There's nothing less than in our design. It's freaking magnificent. It's the wholeness of it and the return to the wholeness that's our job, though. It's not to start blaming the body for showing up with symptoms. And I said this yesterday in our Way of the Master Practitioner, and I've said it before here on Tuesday training as well. When symptoms show up, we as the practitioner don't get to blame the symptom for showing up. There's no blame in the body because it's magnificent, even in its attempt to not have a symptom. And we get to know that. That's what we started our conversation with. We also get to guide our clients to the same. Because if they're blaming, oh, that back of mine, oh, I throw my back out, oh, that bum knee, oh, then what they're doing is creating an adversarial relationship with a body that they want a whole relationship with. And you can't get there from there. You can't be in an adversarial relationship with your body or parts of your body or the symptoms or an anatomical part and expect to have wholeness and the absence of pain. Literally being in an adversarial relationship with you, your body, or your checkbook is adversarial. There's pain in that. It's not peaceful. It's not the absence of agitation. If you want the absence of agitation, you must forego the adversarial commentary on all things, including the body. So we don't get to be all upset about the symptoms and like, ooh, trigger point, I'm going after you. Give me that fluoromethane spray. I'm going after, like, you can't be in that mind space. I wasn't, but I'm using this for theatrics to kind of keep you guys entertained here. But we don't want to have that idea. It doesn't mean complacency and allow them to persist either. We're not designed for pain. We're designed to withstand some of it, and we're designed to have a body that communicates that to us through the central nervous system. But we're not meant to withstand pain. I had someone ask me a week ago, almost broke my heart actually, and I had to swallow and be calm. This person clearly had been experiencing so much pain for so long that it was crystal clear in their question. And the question was, well, I get it that the nervous system is part of it, but how much does the body just get used to a certain level of pain? And what does that do? Like you just get used to it, right? No, honey, you don't, because you're not designed for it. You're designed to have pain responses that we're then meant to mitigate and return ourselves back to wholeness. But there is no end story that says, this is how the story ends. You will be forevermore in pain. That's not how we're designed. So, as practitioners, our job then is to bridge that gap and return our clients' bodies back to their design, where they will then experience no pain. And that includes finding out how it generated in the first place. And that means all of it, all of it, all the pain, all the generating, all the storylines, all the connective points, all the compensatory patterns, all the recruitment patterns, techniques if you have them to start mitigating some of the symptoms so they can feel better while you're doing the work to get them back to how they were designed. And getting them back to how they're designed doesn't mean just quieting the symptom for the moment. Just quieting the symptom for the moment doesn't mean you've returned them back to their design. It could, depending on what you did, but it's rare. If you know it's a symptom and you know the math of the anatomy, there's only a 10 or 20% chance that that symptom is the source of the pain. Most of the time, it's a response to something else, and that response has pain in its vocabulary so that it gets your attention because the body is saying, I can't cope with this anymore. It's doing too many other things. There's too many implications of this awry attitude, behavior, action format. There's too many things that I have to try to make sense of that are not part of the original design. And the too many things that I'm trying to navigate, the body says, is creating havoc for me. And so I need some help in mitigating some of that. And the body will take mitigating some of it and go back to its handling some of the things it's handling until it can't handle all those things again and they return with the same amount of pain. And then you just quell some of the pain from the symptoms, and then it's back to juggling four balls. But what we want to do is just take the juggling act out. We don't want to just quell the pain and have it return and quell and have it return. That's sort of like, I'm going to give you a half gift. I'm going to give you a half gift and call it a holiday. You're okay with a half gift, right? You know what I meant by that. You know I love you. I meant to be generous, but I'm just going to give you a half gift. And the body's like, okay, well, that was nice. Thank you. Right? And then it shows up with pain again, and we're like, you, blah, 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 blah. But I only had a half gift. Right? Like that's literally what we're saying. So, way of the master practitioner is don't be too busy symptom smacking and stacking your techniques unless you are clear on what caused the symptom and what the technique is actually doing to the whole of the anatomy. That's the best use of practices for techniques. What is that technique doing to the whole of the anatomy? The whole of it, the return to all of it. Is the technique only quelling the symptom, which is valuable, right? You got to quell the symptom so that you can get back to doing other work with the body, for sure. But is quelling the symptom leaving the body still juggling four balls of pain that's going to then evolve? Or is quelling the symptom allowing you to return the body back to its design and form and function? Only you know that in the room that you're in with the client that you're working with. But I'm appealing to you all, or those of you who declared that you absolutely want to alleviate pain, and I believe you do. I did too. Hello. That doing symptom work and thinking a technique is the only way is the longer road to where you say you want to go. It's just not going to work, guys. And again, this is no shade on any technique. I've said it a few times, use your techniques, but we want to be thorough and responsible about our use of techniques and not be lazy. And sometimes what happens, and I don't mean lazy to be condescending, so let me just elaborate on that. Sometimes what I mean by that is we want so much to create results, and we've tried for a really long time, and we're tired. We're tired of not succeeding. We're tired of not feeling confident. We're tired of hoping that the treatment plan works. And we're also tired of the same client coming back for the third time with the same complaint. We're tired of that. So we want a magic answer because we're tired. But in the search of the magic answer outside of us, instead of remembering that it's an inside job to create that much knowledge, it's an inside job to generate practice and skill, and it's an inside job to strategically think. That's not coming from a technique outside of you. And that's what I mean by it's lazy to think the technique is going to do it for you. It's a you thing. There's nothing outside of you that's got the answer. There's information outside that you then get to synthesize and use your being to think through it with the client that's in the room with you. I said this yesterday in our training that I started a long time ago when I first started on the internet. It's kind of interesting to think back at that. It was like you put your question in the comment section on social media and it would pop up questions and then I'd type in my answer. And then it would pop up questions, and then we try to like match the questions with the answer. Like we've come a long way, guys. Like we're literally like face to face now, right? I think that was before YouTube. And since then, and still, the most common question I ever get is, Gina, I have a client with X. What do I do? And there might be a version of that. I have a client with X and I tried ABC and this is still their pain. What do I do? Or I have a client with X and somebody else tried ABC on them and then I tried DEF on them and they got a little bit better, but then something else came up in the meantime because of, I think, the work I did. What do I do? It's always a version of, I have a client with X. What do I do? And I realized that trying to answer that question wasn't helpful because it matters to you as the practitioner, the entire history, and I don't mean health history, the entire journey, let's call it that, the entire journey that the body took before it raised its hand and said, I need help. That is different person to person. If one person twists their ankle and now has an imbalance in the connective tissue around their ankle, that is going to affect the tibia, which is half of the knee joint. Client A is going to roll their ankle and have knee pain as a result of walking on that ankle. Client B is going to have foot pain because it's going to affect the intrinsic muscles of the foot below the ankle. Client C is going to have issues with the opposite hip because their body drew a diagonal away from that limb altogether. And client D is going to have an imbalanced sacrum because of that ankle, because of how all the connections make their way up the column and then into the sacred bone. So if you say to me, Gina, I have a client who rolled their ankle and they're having pain, what do I do? I don't have enough information to help you with that because it's specific to how that body translated that experience and the journey that that body took to try to get itself away from pain so that it could be in service to you to keep moving. Which is again why I don't want us to be in adversarial relationships with the body when it shows up with pain. It's kind of like saying, are you kidding me? After all I've done for you? You have no idea what I've done for you to try to prevent this moment of pain. And that trying to prevent this moment of pain is the story that the body went through to try to navigate itself with the injury. And that injury can happen even if you didn't have a quote unquote injury. I remember I used to get feedback from my clients when I'd say, oh, well, that tissue is injured, or when the hip was in, they're like, I didn't fall. I didn't injure it. I just woke up with it. But in my estimation, I know that that means there's an injury there because there's pain, because the journey that the body took is now not the way it was designed. And to me, that means it's injured. But I understand where the confusion lies, like with a client, like I didn't fall, I didn't break anything. There's no black and blue mark. But if I think about it like, oh, it's injured, it needs help, right? Then I can already be in the conversation with the body about the journey that it took before it raised its hand with symptoms and not be like, well, what's wrong with it? What's wrong with your hip? Do you hear the difference? One is like it became injured. What happened? Versus what's wrong with you? That you're acting up with pain. It's not the same. So you don't have to say the word injury, but it to your client, but it does open up this gateway of like, well, what did you do along the way with your legs, your back, your hips, your sitting posture, your standing posture that now made you experience randomly waking up with hip pain? Because it's never random, guys. It just doesn't spontaneously, the body doesn't just combust on itself. It's literally doing the opposite. So if it's doing the opposite, what is it doing? And that's the story and experience line that we get to follow that helps us get back to the genesis. And that's what you treat ultimately. You can treat symptoms. You can use techniques to quell some of the discomfort so that you can do the rest of the work of finding the genesis and returning the body back to its restored function and design. Gary, hi. I was just about
In
to
a
say I'm
situ-
done talking. So glad you read my
Perfect
mind.
timing.
You read my mind. Hi.
So when we're looking in a situation where someone has, say, been hit with something, whether I don't know they were hit with a car door or they bumped their head, or there seems to be some kind of impact at that point to the body.
Mhm.
Are we then still looking for other compensating things that may have happened, or is it smart then to go right to that point, eliminate the pain at that impact point, and then see what happens? I'm a little, what's the strategic thinking here with
Mhm.
something like that?
Great question. And I love that you're like, I want to go to the spot because I want to go to the spot because I want to go where the pain is because I want to go to the spot, but I know that I'm not supposed to do that. I love that, Gary, because
Hmm,
yeah, we get to stop doing that.
that makes sense. Yeah.
Okay, good. Good, good, good. If we just pause our impulse to go to the spot, the pain spot or the impact spot, if we just pause there, so much more information can come through. And that's what I want
Mhm.
for you. So great job. Well done on the pausing. And here's my answer. We talk about this in our practitioner training. I ask the question all the time, what's the impact of what occurred to the body, and what's the mechanical output of that impact?
Hmm.
What's the impact of what happened to the body, and what's the mechanical output of that? So let's say, for example, we're talking about someone hitting their head. I heard you say that. Okay. So someone hits their head. Anytime there's impact to the body, there's a Golgi tendon organ response. As soon as there's a
Mhm.
Golgi tendon, and this is just straight up anatomy, guys. This is curtain number 2. For those of you who are in the master practitioner, way of the master practitioner training yesterday, that's what we talked about. Curtain number 2. How does it all work? We know the parts. Now, how do they actually function? What's the response that they have in life? What's their relationship together as they move this beautiful vessel across the earth? When there's impact, Golgi tendon organs respond. That's their job. It's not a bad thing. That's their job. That's part of the design. When the Golgi tendon organ responds, what type of response does it have to the muscle? And that depends on the type of impact. The other thing to ask when someone has hit their head and we're answering the question, what's the impact of that hit? What side did it hit? Was it front, side, back, top? And when that impact came into the body, what happened to the cranium and the axial skeleton in response to that? What happened to the
Mhm.
cranium and the
Mhm.
axial skeleton and all the muscles and fascia in between? What was the impact? What did that do in the body? So
Mhm.
mostly what happens like in whiplash, and I'm going to switch it just slightly to whiplash injuries, but mostly what happens in a whiplash injury is that the neck goes super, forced forward, forced back, and sometimes forward again. We could have a concussion from that whiplash and be treating just the concussion and not actually
Mhm.
focus on the mechanical impact that's gone on here. Or we don't have a concussion and we recognize that there's inflamed tissues here and we ice them and that's fine. And then we end up with a headache afterward and we're like, oh, it's trigger points. I'm going to work on the trigger points. Instead of what's the total impact on all the muscles that were wrenched in extension and flexion and the fascia in between. And then mostly the alignment of that cervical curve. Because if the alignment of that cervical curve has been disturbed by that forceful movement of the muscles, it doesn't matter what I do to the muscles or the trigger point or the fascia, they're always going to be symptomatic because they're on a crooked frame. They're on a misaligned frame.
Mhm.
So automatically now I have an entirely different focal point than where the head was hit. What happened in that impact to the neck and the fascia and the muscles around it? So now I'm not on where the head was hit. I'm not on that spot, which is what your original question, right, Gary? Okay. And then how long ago was that the hit happened? And what did the body do in the meantime? So let's say, for example, they hit their head on the side and there's Golgi tendon organ response and there's tension over here. We know this in the body. This is a law of the body. The eyes will always find the horizon, which means the neck isn't just going to go back to where it was. It's locked in place from the Golgi tendon organ response and the impact. What it's going to do is this. So now there's a different response that's gone on in the vertebra of the spine that's not the point of impact. How long did that happen? Well, it was 3 weeks ago. And in the meantime, I've been carrying a big heavy bag on this shoulder. And now I went to yoga and I felt better and I did my arms the same because that's what yoga is great for, but they weren't really actively the same. So now it's this shoulder that's hurting from a head injury. So you got to follow what the experience was in the body and what is the mechanical impact of that experience. And that takes a bit to learn. And that's why we spend a year on it, because we just want to work through all the anatomy and how does it respond. And when it's all gone awry, curtain number 3, which we talked about yesterday, when it's all gone awry, that's a completely individual blueprint for that body based on lots of things. Just like I talked about with the rolled ankle. 4 different very probable scenarios, all from the same rolled ankle injury on the same pothole on the same sidewalk. But the body responds differently depending on what it comes to that rolled ankle with. Depends on what it comes to that hitting the head with. From constitution to compensatory patterns and everything in between. And that's what we learn. That's why it takes a minute. You can learn the anatomy. Excuse me. The nature of injuries, though, requires deeper thinking. And there's nothing shallow about learning anatomy. I don't mean to say that. I mean, do the deep dive. Hello, I read the book, right? Do the deep dive. And then the way we synthesize all of that anatomy when there's pain present and injuries that the body has experienced requires a strategy in your brain to take that information and mechanically walk through what's the impact of this and what's the mechanical impact of this. What's the physical impact of the injury and what's the mechanical impact of that? How is the body compensating now that that thing happened? Because now that the compensation pattern is present after the thing happened, that's probably where the symptoms are going to show up. But that's not where it started. Okay. I'm just seeing the chat now, you guys, in YouTube. Gary, did that answer your question? Yes? Okay, great. Simon, smacking the root, start it from the end. Hey, Sherry, mine has Gorilla Tape highlights and sticky notes all over it. What has highlights? What? Oh, your book. Yeah, right? Symptomatologist. I like that, Simon. That's cute. Pacifier, information, knowledge, understanding, wisdom. Sherry, individual, bio, psycho, social, client-centered approach. Great first chapters in Travell too. Yep, everybody has a story. Exactly. What's your take on rheumatologic conditions? Do you mean like rheumatoid arthritis and psoriatic so what's it called? Psoriatic psoriatic
Um,
arthritis, right? Is that what it is?
yeah,
That I'm thinking of? Rheumatoid arthritis and
uh,
psoriatic arthritis. And I think there's another
it's
diagnosis that has rheumatoid in it as well.
it's all from the immune system. Yeah,
Exactly. That I was just going to say exactly right, Gary. That's yes, Simon. Okay, that's your question. Yeah, anytime that there's rheumatoid in there, I know directly go to the immune system. And if that's in your scope, that's in your scope. If it's not, then send them to someone whose scope that is in, because then you're still in service to the person. So one of the courses that we have this month in our membership club is partnering for a pain-free world. And in partnering, the idea is if your vision is to be in service for folks to live pain-free. If that's really your vision, then you will refer out when you know that that referral will eradicate the person's pain or at least target the genesis. Don't just refer people to make them busy. Nobody needs more appointments or out-of-pocket expenses to try. Like partnering means you get to be smarty pants about what other modalities offer, exactly what they offer. When I owned an integrated wellness clinic, that was part of the team's commitment that we all got to deeply learn about each other's modality and what actually we did and the types of results we actually created and what type of client and symptom would be the best to refer to our partner colleague in the next treatment room. And it matters because we don't always know what other modalities are. So only refer if you know that it's going to actually create results and refer if it's not in your lane. So the immune system is 80% of that's in the small intestine because of the microvilli and the lymph ducts that are there, lymph vessels. And if you're trained in gut health, then you can actually address that. Separate hat from massage therapy, though. Like you got to wear two different hats. So I'm actually certified in gut health. I also certify other practitioners in gut health separate from my mastery program because it's a separate hat. And when a client comes to me and they have a rheumatoid condition, rheumatologic condition, as you wrote, Simon, and that's what they want resolved, then I let them know we can do that through your gut health, but I can't also do body work with you on the same day. I have to abide by my license and wear different hats at different times. And don't start being a gut health specialist if you're not, because there isn't a microbiomologist right now. It's a very holistic field that is challenging to Western medicine that is very siloed. So they're having a hard time piecing in where does microbiome practice live? And everybody's an expert. Just ask the internet, they'll tell you. Don't do that, you guys. Don't become an expert on something you're not. Stay in your lane. Please, because that's being a responsible practitioner. That's part of professional development, which we also talked about yesterday in the master practitioner training. Simon, corticoids, NSAIDs, pain alternatives. What's your question? Do I like them? Do I use them? What's your question, Simon? Okay, what other questions can I answer for you guys while we're here? Anything? What questions can I answer for you? I'm sure Simon's typing his follow-up. Any other questions? All right, well, let me share with you some places for Intel. So I already mentioned that this month in our membership club, we're doing Partnering for a Pain-Free World. We're also doing Architecting an Orthopedic Session, which is something that we go through in my Master Practitioner Training program, and then we review it again, and there's always more at the end. So if you've already taken that course, go take it again, because there's more for you in there about how to recognize the symptoms, how to not treat the symptoms, but recognize the genesis. It sets you up for that really well. And then we also have halfway through the month, so it's not opened yet, but midway through June, we're going to also have a training in there on common chief complaints. And I ran through that training and loaded it from TMJ to plantar fasciitis to a whole bunch of stuff in between. It was a really powerful class. And again, remember what I shared today. I have a client with X, Gina. What do I do about it? The answer isn't do ABC, check, check, and check. That's never the answer. But in that training, I take you back through the anatomy so that you could follow the experience that brought your client to that collection of symptoms. And that's what that training is about. So all of that is the focus of the month in our membership club. So if you have not yet joined us in the club and that type of training appeals to you, please join us in there. You can come as my guest for 7 days. And if you didn't yet watch the replay from yesterday's Way of the Master Practitioner training, I had a blast. That was the first time I ever taught that body of information. And we really put it together and got some clarity there. It was, I don't know, was it heavy hitting for you, Gary, or was it light and
You
digestible?
know, I think it was very concise and it filled in a lot of blanks for me about things that I have taken and why was there a hole there, and that's where I need to go to get that piece, and this is how you tie it all together. No, I think it was brilliantly constructed.
Oh, good. I'm so glad that answered some questions for you. That makes me
Yeah, and I
happy.
think, yeah, and I don't know what well, I guess I get an idea about what generated your desire, your commitment to do that particular, uh, you know, 1.5 hour piece of training. But I think it answered questions for a lot of people, and pushed people to go a little bit further in what they thought they needed. So
Excellent. So let's take us a little further
yeah.
than we thought we needed because there's more for you. Yes, there's always
Hmm.
more. That's
Hmm.
my intention is to take us to greener pastures further and farther than we thought was possible. Absolutely. I'm so glad that was good for you, Gary. Thank you for the feedback. So if you haven't yet watched the replay, now you have to register for that. I think registration is still open. I hope I didn't just put my team into a pickle, but it's only available for people who registered, and the replay is only available for people who registered. So if that is a deep dive that you want to take in. It was complimentary, but you do have to register for it. Make sure you grab that link because yeah, it's got a timeline on it. And that is our training for today. So I just wanted to make sure you knew where other things were. And next week we're going to hold on. Simon says physical alternatives to pain management. Physical alternatives to pain management. Pain that causes Does that say insomnia? It's behind that little heart. Pain that causes insomnia, your opinion. If that's what that says, Simon, I will tell you this. Physical pain is not supposed to wake you up, but it could prevent you from going to sleep. If it prevents you from going to sleep, it's because the sympathetic nervous system is on high alert because the body feels like it's in danger. That would be a perfect place to use a technique to quell some of that pain so that you can then get onto the work that really needs to be done. Um, do I have a link for Do I have the link for hall reunion for the study hall? I do. Let me pull that up for you guys so I can put it in the chat while you're here. Otherwise, I'm not sure how I would get it to you. But let me finish my thought on pain. Pain should not, though, wake you up from sleep. If pain wakes you up from sleep, that needs to be handled immediately. And the reason for that is because if you study sleep patterns, which I have, there's a space inside sleep, a long space inside sleep where you don't have physical sensations. So you shouldn't be awakened by pain. That means that is dire. Like I mean, don't say dire to your client, obviously, be thoughtful about that. But when I hear a client say, I was fine, but it woke me up, my heart squeezes a little bit in my chest. And when I've had pain that woke me up, I'm like, oh man, I'm in trouble. Like this is not okay. So it shouldn't prevent you from falling asleep and it shouldn't wake you up from sleep. And they mean slightly different things. Let me grab the study hall link for you guys so that you have it. Hey, welcome back to Practitioner Tuesday Training. That's where practitioners meet. Have happen. Hold on, let me get you the study group, the study hall link. I have it right here. I feel kind of fancy being able to do this because tech is not exactly my favorite place to play, but I like that it puts us together. So let me put it here in the Club Seats chat, and let me go right back to YouTube and put it there too. I will get that for you, Simon, in 2 seconds. So study hall today is 2 p.m. Eastern, so it's just an hour from now. And the reason that I offered you guys to play in study hall today was so that you could, well, first of all, so that you could have that, but also the advocates who are Schatz Method Master Practitioners run the study group. I need to say this. I didn't say this yesterday. You guys, they're volunteers. They're not paid actors. There's no kickback for them. There's no benefit in any way that is pre-calculated that they would want to say anything to you. Okay. I just want to make sure that we're all clear that we're in honest land here. There's no sleazy sales pitching. However, they're committed to the work that they're doing and they're committed to the community, and that is the benefit for them. They like a hardy community. They like practitioners in their tribe who are going places and striving because we are the equivalent of the environment that we hang around. One of the practitioners who runs, one of the three who runs that study hall is also the practitioner who works with Navy SEALs. And so she's the one that gave us the first
Hmm.
idea that we were the SEALs of Bodywork. So for you guys who were in the training yesterday, you heard us say that. So she's there as well. And you could hear her mindset and what their experience was and still is being a master practitioner in the Schatz method. I don't go to those study halls, so you guys can have open-ended conversations. And again, honestly, you guys, they're not salespeople. It's kind of funny how they're not salespeople. So if you just want to hear from them, like how do they use it and how did it change the work that they used to do and the work that they do now, then go to the study hall. That's why I offered it open to you guys for today. So it starts at an hour from now. You don't have to stay for the whole thing. You can pop in and out if that's what your schedule permits. But please go if that feels like it would be valuable for you. We're open and transparent here, and so that's really the purpose of offering that to you. So I want to make sure that you guys have access to that. Simon, there's the link for you, and that's it. Okay, so that takes us right to the top of the hour. How do we do? We cover all the questions, get all the questions answered. Beautiful. Michelle, I'm so glad that you're here in the club seats with us. Gary, as always, I love seeing you as well. I hope you guys enjoy study hall today if that's where you're going, and I'll see you guys next time. Bye for now.